Hello, and welcome to Looking Up, A View from the Valley. My name is Mark Weissman, and thank you very, very much for watching. I'm very excited about this brand new television show that will hopefully be educational and informative for the entire family. If you have any comments on the show, feel free to provide feedback, questions, or suggestions to lookingupvalley@gmail.com or check out our Facebook page and dedicated website. Thank you very much.
I can talk a little bit at Health Initiative for Men in terms of one of the most important things that men don't go to physicians.
Right.
They don't go for screening.
Right.
Right. And then that includes in men specifically prostate screening and of course colorectal screening.
Right. Okay. Good.
And my role in this is to get people to understand the importance of colorectal screening.
Okay. Good.
I've been involved from the beginning of it, and I'm ultimately, I suppose, going to be intimately involved in the colorectal part of it,
Okay.
if not more. But I'm chief of gastroenterology here.
Okay.
I'm a faculty at Yale, teaching faculty at Yale.
Mm-hmm. What do you do? You're in private practice, right? I guess.
I'm a gastroenterology specialist. That's the name of our group.
Okay. So what does your group do to try to encourage and actually promote the fact that men should have these exams done? I mean, there's sort of the inertia of doing it.
Right.
I would think there's the kind of machoism. I think that's part of it, right? I mean, I think
it used to be that way. I think much less so.
Okay.
Yeah.
Oh, I agree.
That's media driven.
Okay.
Mostly because whether you're watching a television show, people talk about it.
Right.
Whether it's some movie star who's on, Leno, who just
Right.
said they had their colonoscopy last
Right.
week.
That's true.
Whether it's somebody like Katie Couric, who's not a man.
No, I understand what you're saying. Right.
But I think, fortunately, from a national perspective, the idea of having a colonoscopy is much less difficult for most people than it was before.
Okay.
There are still a lot of obstacles,
Mm-hmm.
and among those are the things about the fear of discomfort, the fear of embarrassment, the fear of cost,
Sure.
the preparation.
I'm glad you mentioned that because there's, people with Medicare, does it cover all that stuff?
We can get into some of the barriers or obstacles.
Yeah. Good.
We can say how we try to get around those, and I think it's just all it's multi-level. It's done through things like this.
Right.
We try and do as much of this as we can. It's done through talks in the community. It's done through mailings. It's done through our nurses going out into factories and other work environments to try
on the job.
There's
on location.
exactly occupational medicine type lecture series.
When you say mailings, snail and email also?
Well, right now it's been snail, none recently, but email is something we would like to do, but we want to do in conjunction with the hospital.
Oh, I see.
I mean, at some point,
Sure.
we're actually about to get on. Our group is about to get onto Facebook, and
good.
we'll set up a site on that.
Sure.
Page.
Sure. Yeah, absolutely.
Whatever it's called, something on it.
Page. You're right.
Yeah. Email is tough because how do you email blindly?
Right.
You really can't.
Right.
So you.
I think you're right. I think that's where, because they're like, the woman who was just here, her job at Griffin is social media.
Right.
So you get hooked up with the hospital if you're already part of, affiliated with a hospital that has that. They already have. They have a Facebook page. They have a Twitter site. They have all these things that they can do blasts and things like that. So
the colorectal, the long and short is colorectal cancer is not sexy. It's not something which people love to talk about. It's not, until recently at least, the focus of many shows in medicine.
Mm-hmm.
But I think in the last few years, that's turned. And that's mostly because of the success of preventing cancer. We've demonstrated that now way beyond that which we expected to. And that's just through screening. So we can talk about that. We can talk about the concept, even stepping back a little bit, of diagnostic screening in other cancers. We're trying to find things early. That's versus preventative screening, which is an entirely different paradigm. It's you're preventing the cancer by finding something which has not yet become cancer. That's what
versus something that's common now you diagnose and
it's there, but you hope to catch it at an early stage. So prostate, breast, lung, all those are diagnostic screening, which means do it on a regular basis, and if you catch it early enough, survival won't be impacted too much.
Right.
Whereas you're trying to prevent colon cancer. There really, except for maybe pap smears and melanoma screening, there's no other preventive screening that we can do. And given that colon cancer is the second biggest cancer killer, and that we can prevent it, it's a no-brainer.
So wait, a colonoscopy?
Colonoscopy will prevent colon cancer.
Oh,
we're not looking to find cancers anymore. So for people who are scared to have it done because they feel they don't want to have a test that's going to find the cancer, they have to be given encouragement
right.
that we're not expecting to find
Right. It's
cancer.
like a physical in a sense.
It is a physical.
You want that versus, oh, I'm going in because I think I have it.
Exactly,
Yeah. Oh,
exactly,
okay. Oh,
yeah.
that's good.
So if you understand that 90+% of cancers start out as polyps, and polyps are benign growths
Right.
that may take anywhere from a few years to more than a decade to become a cancer.
Mm-hmm.
The biology is different in different people, it's a little complex, but essentially it's about, we think, somewhere between 7 to 12 years for polyps to become cancers.
Mm-hmm.
So if you're looking for these polyps, which are like bumps and lumps,
Right.
and you find them, and you look carefully and remove all of them that are there, that way you've prevented cancer as long as people come back within X number of years.
Mm-hmm.
If they don't have any polyps, then they come back in 10 years. And there's probably somewhere around an 80% chance they'll never get a cancer in that time period.
Wow.
We used to hope it was more than 90. There are other variables involving, including faster growing polyps than we thought, including perhaps the fact that there are always going to be missed polyps no matter how good we are.
Right.
But taking those out, you're likely to prevent colon cancer more than 80% of the time just by having routine colonoscopies.
Wow.
So if people understand that, if somebody comes to my office and they're unsure about whether or not they should have a colonoscopy, they're scared, they're worried about it, whatever the reason is. And this happened to somebody this morning.
Oh, okay.
The first thing I asked them is if we could do a test, one test, that would prevent them from getting cancer, would they go for it? It's a no-brainer.
Right.
Nobody
Of
says no
course.
to that.
Right. Exactly.
So of course I have to change that a little bit. And I have to say,
Yeah,
okay,
yeah.
the problem is we don't have that for every cancer,
Right.
but we do for the second biggest cancer killer. And yes, it's not 100% prevention. We hope that it's 80%, perhaps even as high as 90%.
Mm-hmm.
But that's pretty good. We can't offer that in any other cancer. So most people actually, once they hear that, then those other issues of fear of the procedure or perceived discomfort
Right.
or the
Right.
preparation or embarrassment, those become really so secondary that we can get rid of those. We can assuage their fears on that within a couple of minutes.
Wow.
And I really hope that people get the chance to ask those questions. The biggest problem is there are, one, barriers because primary care physicians often forget to or don't include recommending colon cancer screening as part of their annual visit.
Mm-hmm.
They don't want to cause discomfort among their patients. They don't want their patients to feel like they would be embarrassed. Or they don't want, they don't think about...
I mean, just you're risking cancer because someone doesn't want to feel embarrassed. I mean,
Good doctors can nicely but firmly plant the seed of something like this in their mind.
That's right.
But they have to understand what I just said too.
Right.
They have to understand sort of the academics behind it. They have to understand
Mhm.
the concept of preventive screening. They have to be able to tell people that all these horror stories of
Mhm.
pain,
Right.
of embarrassment, they're just really not true.
Mhm.
In terms of pain, people are well sedated. It's so unbelievably unusual to get pain that we don't worry about that anymore.
Mhm.
The patients really almost always, when they leave the procedure, will tell you that. In terms of embarrassment, I'll tell people the same thing. I don't really care what your outside looks like. I'm only looking at your inside.
Right.
I don't remember anything. I have done procedures on patients
Sure,
who are
sure.
friends of mine, and I'll meet them at a party 6 months later. I honestly don't remember having done their colonoscopy,
Right.
unless they were mine.
Right. It's-
So embarrassment really shouldn't be a part of it. I mean, we are physicians and you're patients, and that's really what it should be.
Mhm.
In terms of the hardest part of it, the preparation, yes. We could clean your colon out over a period of 1 to 4 weeks,
Mhm.
but that would be silly. That would be a terrible time. In order to be able to do it within a 1-day period, which is reasonable, we're going to have to give you something which is going to make you feel a little bit like you have a viral disorder.
Right. Right.
There's no way around that. But it's worth that day in order to know afterwards that you're not going to get colon cancer.
Sure.
Either because you
And
don't
that
have
feeling,
polyps.
that viral feeling, is that only for the one day?
Yeah, yeah.
I mean, that's
That's
you
it.
know,
It's
a
just
lot of
like-
viruses last a lot longer than that. So.
Right, it's actually not even a viral feeling, it's just
Right.
running back and forth to
Sure,
the bathroom. You
sure.
don't have that
Yeah.
same sort of malaise you do with the
That's
virus.
true. Good point. That's
Um,
true.
But again, granted, that is the worst part of it, but in order to be able to prevent cancer, we have to be able to find those small polyps, not just the ones that hit you in the face.
Right.
And to see those small polyps, you have to have a very good preparation and clean out of your colon. So yes, the onus is on the patient to do the job they're supposed to in terms of taking that laxative and not sort of drinking half of it and
Right.
coming in the next morning and saying
Right.
something like, oh, I did it all.
Right.
You're not fooling anybody, you're just not getting a good procedure.
Yeah.
So yes, that's the most difficult part of it. There are different ways of doing it. I think we use 6 or 7 different preparations in our office, and
Mhm.
it's somewhat individualized.
And where is your office?
Our office is on Westfield Avenue in Ansonia,
Okay.
and we have a satellite in Oxford as well,
Oh, really? Where in
on
Oxford?
Oxford Road.
Oh, in Oxford. Okay, good. Excellent. Now, the You mentioned, though, with the primary care physicians, obviously you're trying to get the word out with potential patients or hopefully people who do the diagnostic. Is your group doing anything to encourage primary care to kind of go against what their feeling is about keeping their patients at ease and recommending these other cancers?
Yeah, I mean, I don't want to make it seem like we're blaming primary care physicians. I think that what they do is much harder than what we do. I think what we try and do is lecture in the community and tell the primary care physicians that there's an opportunity for their patients to come to those things.
Right.
So that at least if they don't want to talk a little bit about this or explain things or get into the nitty-gritty of it, or if they feel like it'd be better for us to do it because we know the subject and probably convince their patients, that's an option, as long as they know that there are lectures that they can go to.
Right.
From an academic standpoint, we're always giving talks at Griffin and elsewhere for primary care physicians, so they understand the latest about what's going on in the field.
Oh, good.
And when we interact with other physicians, we'll also let them know that if there's even a question about a patient not wanting to have it done but they need to be convinced, I'm happy to talk with those patients on the phone or see them in my office gratis, just so we can get the word out.
That's nice.
We're going to do more. I think we're going to have a Facebook page. We're setting that up now. I think we need to work more with social media. That's important, especially as the people of screening age, which is 50 for colonoscopy, are the people who were the initiators of the social media in the beginning 10 years ago or so.
Right.
They're getting to that age now where they need colon screening. They're looking at the internet. They're looking at social media. So that's important as well. What else can we do? I think that, to some degree we count on what the media does as well. And we hope that the push towards colon screening by people like Katie Couric and other people in the media continues, because it's been very successful. There's something called the Couric effect.
Oh, really?
She, by herself, has been estimated to have increased colon screening, specifically colonoscopy, about 20%.
Really?
Yeah.
That's amazing. Yeah. Is that for males and females?
That's across the board.
Across the board. Wow, that's amazing. I mean, that reminds me, when David Letterman, when he had his heart surgery and things like that, Dr. Oz, we talked about him having cancer publicly.
Right. Dr. Oz had a 5-part series on colon screening. He was found to have a polyp and it was removed, and he did a very reasonable job at instructing people about the necessity to go for colonoscopy, and that how if you find a polyp, it doesn't mean that that's anything bad. As a matter of fact, when you remove it, since it is the precursor to cancer, but it's still a benign lesion, you have prevented cancer.
That's all. So all polyps are benign. Is that what you said?
Well, by definition, a polyp is a growth.
Okay.
Not all polyps are benign. The majority of them are. You can have early cancer in a polyp, and then it's called a malignant polyp. But in many of those cases, if you remove it like you would remove any other polyp, you don't have to have surgery.
So it's basically isolating where it is.
Right. Okay. So polyp is a growth. Almost all of them are benign. Many of them have no potential to become cancer. Some of them, which are called adenomatous polyps, have potential to become cancer, but they have to evolve. They have to go through a series of at least 4 mutations over a period of many years, and most of those won't have all those mutations occur. The problem is we have no way of knowing when we see a polyp whether or not it's going to become a cancer. So we remove all of them.
Okay. Interesting. Now, one of the things too, I would imagine that if someone is hesitant about doing some of these preventive screenings or diagnostic screening, is because of the insurance. And I don't know if there's a percentage of patients that are on Medicare, or maybe they're just out of work, so they don't have insurance, or the insurance is expired. So is there any advice or anything from your experience that you can speak to about?
Well, in terms of screening, because of what was pushed nationally, and many of the insurance companies follow this, if you have a policy, this includes Medicare, by the way, which covers screening, it also has to cover colonoscopy.
Oh, okay. So in other words, anything that's considered to be preventive, that would fall.
So there may be either no deductible or copay, or a very small one. Now, the problem with that for colonoscopy is that there's been this loophole that's been allowed at the federal level and hence at the state level as well, where if you start off with doing a screening and you find a polyp and you remove it, the insurance company is now allowed to say, okay, that was not a screening examination.
Oh, yeah.
That was actually a therapeutic examination because you removed the polyp.
Right.
So even though, had this been a screening with normal findings or negative findings, and you wouldn't have paid anything, Now we're going to charge you whatever copay or deductible our plan allows you to do.
Sure, I see what you're saying.
And this has been a problem that's been being addressed federally, but of course, given all the problems with healthcare dollars and the lack of those,
Right.
it may take a while to correct that. At the state level, there's actually been some movement on that, and it's passed the legislature already, at least in the House, and it's in front of the Senate. And Griffin was actually the initiator of this.
Oh, really?
Right.
Wow.
And so I believe it's going to be pretty close that Connecticut will be among the very few number of states soon that will not allow that loophole to occur. Once that happens, if you go for a screening examination,
Right.
in many plans, not all, but in, let's say, probably most plans, because most plans have a screening provision,
Right.
there won't be any cost,
Even if they do find something.
even if something's found.
Okay.
So we hope that's going to be the case too. So that's going to help. Clearly, I think, besides that, it's the onus is somewhat on the patient to understand what their plan is. Unfortunately, we have too many plans, it's too complex. It's very difficult for even individual physicians' offices to know everything about everybody's plan.
Mhm.
And we try our best. We do call for every single patient who comes in, we call their insurance, we find out what's covered, we find out what their obligation is going to be if they have any, and we let people know. And most of the time, it's bearable, and they'll go through this because they realize it's an important thing. Sometimes people have been putting off their screening because either the deductibles are too high, or their co-pays, or both. And that is still a problem, and I think that's got to be addressed by higher powers than we can at this point. There has to be legislation.
Interesting. Wow. Now, you talked a little bit about some of the latest technologies or things like that. First of all, do you yourself get involved in any research side of things, or is it all basically practice and execution of what you do?
Well, right now, I used to do clinical research. Right now, I'm mostly involved in practice. Do some research projects. I'm doing a survey, a questionnaire, myself and our group, as well as the Yale Gastroenterology program, on whether patients are aware of some of the quality indicators in colonoscopy, like whether or not physicians that they go to have good ability to pick up polyps,
Oh, okay.
what their number of picking them up is,
Right.
because there are standards that are coming out now,
Mhm.
or whether they're doing complete colonoscopies or can't do complete colonoscopies because they have technical issues. So those are quality indicators.
So
They're
primary
eventually-
care physicians can do colonoscopies as well as?
No, I'm talking about gastroenterologists. So the
Oh,
research I'm
okay.
doing now is really just it's a questionnaire that we're giving our patients beforehand as to whether they're aware of these
Oh,
quality indicators,
I
and
see.
whether, even if they aren't aware, whether something like that would be important. Would it be important for them to know, like going on an internet database,
Right.
whether or not their physician picked up adenomatous polyps, those precancerous polyps, 10% of the time when they do procedures, 20% of the time, which is accepted right now,
Mhm.
or 40% of the time, which means they're looking more carefully than anybody else does.
Oh, wow.
Would they like to know that kind of stuff?
Oh, yeah.
Right. Right now, we're really entering an age where we're about to have that stuff online, and that's going to be government mandated.
Mm-hmm. Oh, really?
It is.
Wow.
We're not there yet. So some of these quality indicators, and other ones would be whether or not patients are satisfied. There are a whole list.
Sure, yeah.
That's what the government, and that's what some of the large sort of organizations that are proposing changes in healthcare are saying should be an integral part of the patient plan, that they should be exposed to or have access to their physician's quality. Now, how do you measure quality? We can go into that
Sure.
all day long. Some of these are just statistics, and sometimes statistics really is not the best way
Right,
to
it
measure
can be
it.
very subjective.
Exactly.
Absolutely.
Or maybe it's too objective without the subjective.
Oh,
But in any event, so we're starting to look at that and see whether or not patients really care about that. So you asked about clinical research. I guess I digressed.
Right, no, that's okay.
And I hope to get more involved in other projects along with Yale. But at Griffin right now, we're really concentrating on trying to make sure that our patients get the screening tests done.
Mhm.
As soon as our numbers come up to those that we think would be good, you could say 100%,
Right.
but certainly more than 50% of the Valley population, I think we can concentrate a little bit more on research too.
Now, as far as just in general, I mean, I imagine even if you're not involved in research, you're reading journals or things like that. I mean, it's sort of the latest technology, either from a diagnostic standpoint, is there something that's sort of on the cusp or on the verge of maybe making it a lot less embarrassing or a lot less invasive, things like that, and also the actual treatment side of things. When you've been diagnosed with cancer, are there things, what sort of state of the art or even soon to be state of the art that's
So
actually?
I'm going to divide that up into sections
Yep,
here. Right?
exactly.
So the first thing I have to do is correct you because you said embarrassing and invasive, and I'm going to flip that around. I'm going to say it's not embarrassing for many reasons. One is I don't really foresee a case where I'm going to be concentrating on somebody's exterior. I think I mentioned that.
Okay.
So embarrassment to somebody, again, this is subjective, could be embarrassment because they're going to be exposed.
Right.
Well, we don't expose it. Embarrassment could be because we're dealing with parts of the anatomy that we don't think about all the time, right? And so because we don't think about them, or because they have negative connotations,
Right.
or some of this, is superstitious, some of this is maybe perhaps ethnic, some of this, whatever it is, if you can get over the fact that this part of the body is something we don't talk about all the time, if you can get over the fact that this part of the body is, quote, dirty, which it really shouldn't be if you think about it realistically, there's nothing to be embarrassed about.
Good point.
I'm a physician who's trained in this,
Right.
and I stopped counting at 10,000 colonoscopies. I've done way more than that. I don't even look at that in the same way that you would imagine it being embarrassing. So by the time you go home after having this test, and I've told you you're not going to get colon cancer, that embarrassment part of it doesn't even enter any future thoughts or discussions. So I think that it's something, that's one of the biggest problems we have. Embarrassment is certainly there. People have to just basically say, I'm going to prevent cancer. For myself, for my family, I'm going to prevent cancer. And the embarrassment, even if you can't get over that, is such a tiny percentage of it.
Right. Do you do anything, does your group do anything to sort of, from a psychological standpoint or preparation or mentally sort of get over that before you, in other words, if someone comes to you, they've sort of already put aside some of that embarrassment because they've actually gone and actually had a conversation about it, but then you have all the people that maybe are afraid to even bring it up, or I don't want to even think about it, and they're not even to a point where they're actually being affected by your alleviation.
Right. So whether you see a physician or whether you see our nurse practitioner, I think that's always part of our conversation. We'll go through some of the perceived difficulties of embarrassment, of pain, of the preparation, and also of the potential complications. And we'll address those one by one, even, this is proactive.
Oh, good.
Just so people understand that which you may have heard is not the case. That will not only benefit them for heading into their procedure, but hopefully they'll be able to spread the word to other people as well. They'll remember that conversation that we had with them. And after their procedure is done and they feel good about it, they will then begin to tell their colleagues, their friends, they'll tell them that they benefited from having that colonoscopy. And if they remember 10% of what we told them in the office about how some of those things, those fears really shouldn't be there, they'll be able to relate that.
Sure, absolutely.
So it's good marketing starts right in the office.
Oh, absolutely.
So you asked me about new technology.
Right, correct. Either from a preventive or diagnostic or even treatment.
Right. So colonoscopy is the gold standard. One can have testing of the feces for blood, which is called fecal occult blood testing. But that's been shown really not to pick up polyps very well. We want to stay in that preventive screening mode. We don't want to get into the old days of finding cancers just because somebody has blood in their stool.
Right.
So that's is it effective? It's pretty effective at picking up cancers. But do we want to get to that point? We really don't. If people don't want to have colonoscopy, and it's better than doing nothing.
Right.
So certainly it's still in all the different task forces, the federal task forces, and all the society recommendations, fecal occult blood testing is certainly still recommended, especially for those people who will not have a colonoscopy. There are other tests that are available, including a flexible sigmoidoscopy, which is really just a partial colonoscopy of the rectum and a little higher.
Right.
And that will help prevent cancers of that side of the colon, but not colon cancer all the way around.
Oh, I see.
From a cost standpoint, from a societal cost standpoint, obviously that's beneficial. But if you actually end up doing those models, those cost models, it's still more beneficial to do colonoscopy because you prevent cancers in general rather than just part of the cancer.
It's more comprehensive.
It is. But there are people who will only have those, and so they should be offered. Barium enema, which is a radiologic test that was done decades ago essentially at this point, really is almost never done. And radiologists have gotten out of the habit of doing it, so they don't do very effective studies, and they'll be the first to admit that. There are other modalities that are available, not yet paid for. One of them is CT scanning. So you can have a CAT scan done of your colon, which is called variably either a virtual colonoscopy or a CT scan colonoscopy. They end up calling what we do an optical colonoscopy. There have been a series of studies over the last decade on that. Generally, one has to have a preparation anyway. That may change. That would make it better. Generally, you have to have air blown into your colon to distend it because your
Right.
colon really is not insufflated to begin with.
Right.
And then you have a CAT scan done. And then it takes a radiologist a period of time to be able to go through it with a joystick in a software program as if they're doing a colonoscopy. For polyps that are sizable, those that we are concerned about, that we know already have a risk of turning into cancer, the pickup rate for polyps is quite good. It's comparable to archetypal colonoscopy or optical colonoscopy. For smaller polyps that are, let's say, 5 millimeters or less, it really is nowhere near as good to pick them up. So there are many questions about CT scanning, and this is still a matter of debate. What's the significance of missing small polyps? We don't really know completely what the answer to that is.
Now, I guess I'm just thinking before we go on, there's always that comparison, like CT scanning to MRIs, and, as far as bones and ligaments and tendons. Is there a similar difference? In other words, if you were to do an MRI on your colon, would that actually improve the likelihood of finding polyps? Or anything?
Right, so MR colonoscopy right now is not really even a modality available.
Okay, and why is that?
As far as I know, it's really just in its infancy stage, and CT scan is much better for looking at that type of tissue than MRIs, looking at the gut. So that's changing, because we are using MRs more for things like Crohn's disease and small bowel disease and so forth. So that may change, but right now CT it's not really available at all at the clinical level.
Okay.
So the question then is what happens if you miss these small polyps? How often should you have CT scanning done? That's not really been worked out, although the radiologist will say 5 years. And then what's the significance of the radiation exposure? Because we do know that for every CAT scan you have done, and this is a relatively high radiation CT compared to others, there is a risk down the road of one in many thousands perhaps developing a cancer as a consequence of having been scanned.
Wow.
So why would we want to worry about that? You still have discomfort because you're still having air blood in, right? You still have to have a prep. That may change.
Are you sedated during that, or
no?
You're not. Okay.
No. Perhaps the biggest problem is the closer we look, the more we find adenomas, or precancerous polyps. Right? As I said before, for men, the acceptance rate right now is about 25%. If you don't find 25% of your patients having adenomas, you're probably not looking carefully enough. Right? So the big problem is, as we look more and more, and we find adenomas more and more, and we remove those, then A, what's the significance of not looking for smaller ones, as with a CAT scan? And B, even if we found the small ones with a CAT scan, how many people have to go through a prep again and have a colonoscopy done in order to remove those polyps?
Right.
So really what the American College of Gastroenterology argues, and rightfully so, is until a modality both picks up a large amount of precancerous lesions, as well as gives us the opportunity to remove those lesions, like you can with colonoscopy, until such a modality exists, separate from colonoscopy, it's very hard to argue to replace colonoscopy with anything else. You're not going to be preventing cancer at the rate that we now know we've begun to do. In the last decade, we've seen a drop in the cancer rates. And study after study is coming out right now that are follow-ups to those 1990s era studies that show that taking out polyps prevented cancer. Well, we now have studies that we look at now retrospectively, and we're proving that's the case. So for the first time ever, the number of colon cancers nationally is coming down.
Oh, wow.
Incidence is coming down, and the rate of colon cancer deaths is now coming down too.
That's interesting too, because there's a lot of, just in general, it seems like the more advances you have in medicine, then you detect it more. So sometimes the rates will go up, even though it's not really getting higher. It's just because we're now investing.
Right, and that's the difference between preventive
So,
screening
right.
and diagnostic screening.
Yeah.
So we're finding more polyps, we're preventing more cancers.
Right.
We're not finding more cancers.
If you have any comments on the show, feel free to provide feedback, questions, or suggestions to lookingupvalley@gmail.com or check out our Facebook page and dedicated website. Thank you very much.